Today we are going to study about calcium and phosphate metabolism under mineral metabolism in biochemistry. So, starting with calcium metabolism. First of all, there is about 1 to 1.5 kgs. How much? 1 to 1.5 kgs of calcium in our body. 99% of which is stored in bones. That's quite obvious, actually, no surprise. Talking about the sources of calcium. We all know it's present in milk, fish, egg, etc. And that's quite obvious. Milk is a pretty good source, actually. But what we do not know and what is actually important is that cereals, which are rather deficient in calcium, are so dominant in Indian diet that cereals form the major source of calcium in Indian diet. Okay. What's the daily requirement of calcium? Well, daily requirement of calcium. Vasudevan suggests otherwise, but we should listen to Park textbook of preventive and social medicine because it gives reliable data about Indian population. So, and it actually gives pretty simple data for calcium. So it says 1000 mg per day. That's just 1 gram, 1 gram per day of calcium for all of males, females, as well as pregnant females, and only for breastfeeding females. It says there should be 20% increment and made 1200 mg per day for breastfeeding females. Right? This is the daily calcium requirement. Absorption. How does absorption occur of the calcium that is present in our diet that we take in? Pretty simple. Actually, it is majorly absorbed from the proximal intestine. So the more proximal we get, actually, the better our answer gets. So obviously duodenum more than jejunum, but even in duodenum, the first part of duodenum absorbs more than the second part of duodenum for calcium, right? Factors increasing the absorption of calcium. What are the factors that increase calcium absorption? Vitamin D, parathormone. These are two hormones. Vitamin D, yeah, it works everything. It does a lot of things that's gives it enough credibility to be called a hormone. It absorbs a lot of calcium from the gut. That's actually its main function. PTH absorbs calcium from the gut, but not directly. It increases vitamin D level, and via that, it increases calcium level in the blood. Right? Acidity, much like we study for iron, increases calcium absorption, and 2 amino acids, lysine and arginine, are also said to increase calcium absorption. There are also things that decrease calcium absorption. What could they be? Well, first of all, phytates or phytic acid decrease calcium absorption, and these are actually present in your cereals. Then come oxalates. These are present in green leafy vegetables, and these again decrease the calcium absorption. Then malabsorption syndrome, quite obvious, the name says it all, decreases calcium absorption. And phosphate. Well, phosphate makes calcium useless in the entire body, so even during absorption, phosphate does the same thing. It just forms calcium phosphate, and calcium is not ionized anymore. All of a sudden, it's completely useless. Now, Vasudevan says that there is an ideal range for calcium to phosphate ratio for good absorption from the gut, and it ranges from 2:1 to 1:2. The numbers are that you can just inverse calcium and phosphate, and it will still be the right answer. Functions of calcium. Calcium performs a lot of functions. First of all, activation of enzymes. For this, you need to know one important name, calmodulin. Calmodulin is a protein that binds with 4 calcium ions and activates a lot of enzymes. Now, the enzymes are in fact a lot, so you need not remember their names, but you can remember a pattern that a lot of their names end in kinases. For example, pyruvate kinase, phosphorylase kinase. There's something called myosin kinase. There's also calcium-dependent protein kinase. But even without binding to calmodulin, calcium still activates a lot of enzymes. For example, pancreatic lipases and enzymes of coagulation pathway, and also renal. These it can activate without binding to anybody. Now, second function. You must have read this one extensively in physiology. Calcium helps in muscle contraction and all sorts of muscle contraction. So skeletal muscle, smooth muscle, cardiac muscle. Skeletal muscle, you just know that the voluntary muscles. Cardiac muscle contraction, that's just also systole. And smooth muscle, one you should remember separately is that smooth muscle is present in blood vessel. So by contracting the blood vessels, calcium is able to alter the vascular permeability, right? Third one, and very important one, nerve conduction. Now we all know that sodium is the one that actually stimulates, depolarizes the nerves and actually causes nerve conduction. So what does calcium do? Well, calcium just doesn't let sodium do its work. So sodium tries to go in and depolarize the nerve, but calcium just doesn't let that happen. It stands guard at the way, and ultimately you can just remember as a rule of thumb that calcium levels are inversely proportional to nerve conduction or nerve excitability in the body, right? And this is a very important clinical application known as tetany that we will come on to soon enough. What function are we on? Function number 4. Function number 4, it helps in secretion of hormones. That's quite intuitive, it just secretes them, really. Function number 5, it acts as secondary messenger. What's a secondary messenger? We read very extensively about these in pharma when we are studying about reactions. There's something known as G protein couple receptor, and there's one special one known as GQ. GQ is involved in a pathway known as IP3DAG pathway, and in this pathway calcium acts as the second messenger and ultimately leads through the drug action. So, well, you can safely forget every single one of these letters and digits alike and just remember that calcium acts as second messenger for some drugs. That's good enough. Number 6, calcium is so important for coagulation that it is in itself labeled as a coagulation factor and it's said to be coagulation factor number 4, right? And then the last function, most obvious one, 99% of it is stored in bone and teeth, so well, it makes up bone and teeth. Going on to some pretty important numbers. What's the normal blood level of calcium? We will study about phosphate levels as well, but they are not nearly as important as this guy. Normal level is 9 to 11 mg per dl, and you must really remember this number. Below 9 is hypocalcemia, above 11 is hypercalcemia, and on different ranges there are different manifestations of hypo and hypercalcemia, but you should remember the ideal range at all costs, right? Now you should know a very important concept that only ionized calcium, I think I kind of hinted it earlier, ionized calcium is useful in body, right? Calcium that is not in this form is useless. So there are a few things that are quite fixated on making calcium useless. One of those guys is phosphate and another one is albumin. So well, albumin doesn't really make it useless, it just carries it around, but while it is being carried around, it doesn't do much, so it is useless. The level of phosphate bound calcium at all times is nearly 1 mg per dl. The level of albumin bound is nearly 4 mg per dl at all times. So if we just average this one out to 10 mg per dl, so we can see that ionized calcium at all times is around 5 mg per dl, and this is what does every single function that we enumerated just now, right? So let's come on to the hypo and hypercalcemia thing. Hypercalcemia, right? So what's hypercalcemia? We just read that if it is 9 to 11, that's normal, so more than 11 is going to be hypercalcemia. Now, when to suspect hypercalcemia? Renal calculi, recurrent renal calculi is actually renal stones, you can just call it for simplicity. The most common presenting feature of hypercalcemia. The second one is ectopic calcification. These are things that when you see them in a patient, you should try to probe the calcium levels, look after the calcium levels, and it should make you think that something may not be right with the calcium metabolism of the patient. Ectopic calcification, and the third one will chronic renal failure. There are more, but these three are pretty important. Malignancies. I think I already went over PTHRP, or I may not have been over, I did not yet. Malignancies, when patient has, they are quite insistent on deranging the calcium levels in the body, so we should look after the calcium levels when the patient has a malignancy. Also, ectopic calcification. There are two types of ectopic calcification actually, dystrophic and metastatic. What's the difference? Well, dystrophic, not metastatic. Dystrophic calcification, the tissue itself is not in the best of conditions. Like it is usually quite necrosed, or there may be a tumor, or there is a very gruesome infection, for example, myocystis in brain, or many tumors like meningioma in brain again, and the peripheral necrosis and things. They attract calcium, and calcium need not be elevated to cause this kind of calcification. It's just the tissue which is at fault. Metastatic calcification is different. This happens when calcium levels are really high and the tissue is quite innocent. It hasn't really done anything. The calcium just invades and starts depositing. This is seen in pancreas. Can theoretically occur anywhere. Now, well, what are the causes of hypercalcemia? Let's talk about it. Well, theoretically speaking, hypercalcemia can be due to any cause that we have read till now. All of the intuitions, like one could say that excessive calcium intake can cause hypercalcemia. Well, obviously, why not? But practically speaking, the most important cause, major cause of hypercalcemia is, I should give it more space, hyperparathyroidism. That is elevated PTH levels in the blood. Now, this itself can be due to two causes, majorly speaking. First is parathyroid gland adenoma. What's parathyroid gland adenoma? That's a hormone secreting tumor of the parathyroid gland, mostly benign but still quite problematic. And the second is due to peripheral malignancy associated. What? Peripheral random malignancy associated. What they do is actually will house that hyperparathyroidism because they release something called PTHRP, parathyroid related peptide, and this does everything that parathormone does, that is increases the calcium level, just like this increases the calcium level. You should know a few important malignancies that release this. First and foremost is squamous cell cancer of the lung, and others will include breast cancer and prostate cancer. Now, come on to hypocalcemia. The important thing that we have to know, well, the level will be less than 9, that's when you call it, but the important manifestation that we have to know is called as tetany, and this is a very important manifestation. Tetany doesn't occur unless the level is as less as 7.5 mg per dl. And what is tetany? Well, the basic funda is that, remember how calcium levels were inversely related with nerve excitability? Well, the calcium levels are now so low, the nerve excitability is very high. And what does nerve do after excitation? It excites the muscles, right? NM, muscarinic nicotinic junction, whatever. It just excites the muscles, and this undue excitation that muscles are getting all the time causes them to go into spasm. So theoretically, all muscles in the body due to tetany can undergo spasm. You need to know 3 important muscle spasms. First one is the most common cause of death in tetany. Well, I said that it's due to a spasm. Which one could it be? It is due to laryngeal spasm. It's quite the pattern in medicine. The other 2 are actually clinical signs that help us diagnose tetany. First is Chvostek sign, and the second is Rojo sign. You need to remember a few words for both of them. Chvostek sign, you tap on the facial nerve of the patient, that is cranial nerve 7. And what does the cranial nerve 7 supply? Well, motor supply we're talking about. So it supplies the muscle of facial expression. So suppose you are tapping on the right-sided malleolus of the patient. You start to tap on the facial nerve anywhere along its path, and you will see that side of the facial muscles undergoing spasm. They start twitching. For Trojo sign, what you need is a sphygmomanometer or just a BB cuff. You need to inflate it, and that's when you will see it, carpopedal spasm. What's carpopedal spasm? That's the name kind of gives it away. Carpal bones. The hand just kind of looks like this. This is your forearms, his hand, these are all fingers, all everything going in flexion, right? That's just carpopedal spasm. And you need to remember that the BP cuff needs to be elevated, needs to be inflated for minimum 3 minutes before you can say that yes, it has in fact undergone carpopedal spasm, or before ruling out nausea sign and ruling out tetany altogether. In any case, if you see this, you must attend to the patient before this happens. Now, talking about phosphate metabolism, much less yielding than calcium metabolism. You could safely forget everything. I'm going to say this moving forward. Just kidding. Body has 1 kg of phosphate, and 80% of which is present in bone and teeth, and 10% is present in muscles. Now, functions of phosphorus, you not write anything. Well, obviously there's so much in the bone and teeth, and it forms a bone and teeth. It deactivates calcium. That's also kind of a function, because well, if the ionized calcium increases, that's a problem, as we have seen hypercalcemia in this moment. So phosphate is also involved with ATP, GTP, the energy currency, NADP, that is nucleoside coenzyme, and any other enzyme activation by phosphorylation. There's also something called phosphate buffer system in blood, and the name gives it that phosphate plays a role in that one too. Requirement of the phosphate, source of phosphate, well, requirement is 500 mg per day. This is also given data, but doesn't have to say anything about it. And milk is yet again a very good source for this guy as well. What about serum levels of phosphate? I told you calcium levels in blood are quite important to remember. Phosphate levels are not that important, but if you remember calcium, you can kind of remember phosphate. 1/3 of both these numbers, 3 to 4. That's just the normal serum phosphate level. So if you can remember it this way, there's no harm in remembering, right? Now let's dive into a very important concept. That's the homeostasis between calcium and phosphate, maintained with hormones, parathyroid hormone, calcitonin, and vitamin D. Let's just get an intuitive construct. This is a tie-up between physiology and endocrine physiology and biochemistry. PTH will do everything in its power to elevate the calcium level in blood, ionized calcium level in blood. Okay, everything has to do with ionized calcium. No one else. Calcitonin will do everything in its power to reduce the ionized calcium levels in blood. And vitamin D3, I'll say that vitamin D is quite docile and it will make reasonable decisions. So what do they do? Let's just get a brief overview. PTH, the major function is resorption of bones. The first line we read in this class was that 99% of body calcium is present in bones. So that's the major reservoir, and if it has to do everything in its power to increase body calcium, it must mine the reserve site, so it will cause resorption of the bones. Now, of course, that's not that good of a thing, because that will make the bones weak. So somebody's going to counter it, and that is this guy. I'll talk about it later. What else PTH will do? PTH will increase calcium absorption from gut, but only via vitamin D. Right. So what PTH will directly do is increase vitamin D synthesis from the kidneys, and this will increase calcium absorption from the gut. Up next, PTH is sometimes called phosphate throwing hormone because it throws away phosphate from the kidney. Well, it almost looks like a kidney. It throws phosphate out of the kidneys. Why? Because phosphate decreases the ionized calcium level in blood. So PTH is a natural enemy of phosphate. And other things, I don't think PTH does all that. Anything else? Up next, we talk about calcitonin. Calcitonin will cause bone formation, and for that it will utilize the serum calcium levels. Calcitonin will decrease the reabsorption of calcium from it will absorb calcium reabsorption from the kidney, right? It will decrease this, increase this. Makes sense. It will decrease the reabsorption of calcium from kidneys, and that's major function. This in fact is the major function. Now vitamin D makes some sensible decisions. Vitamin D will cause gut absorption of calcium. Why? Because we need calcium. Vitamin D will reduce the calcium excretion from the kidney. Vitamin D will also reduce the bone resorption. So this one is going in a different direction from the other two, but it makes sense, right? It doesn't want to make the bones weak, right? What else? It also actually reduces the phosphate excretion. So 2 in one direction and 2 in the other direction. I think I have covered everything pretty much of important things. Let's say vitamin D, I remembered. You should know that vitamin D can never possibly cause tetany, vitamin D deficiency. Like we talked about hypocalcemia manifestation tetany. Vitamin D deficiency will definitely cause calcium deficiency, but the deficiency is not as big as less than 7.5 mg per day. It will only be slight deficiency for prolonged duration and leads to manifestations like rickets and osteomalacia. Whoever will discuss the vitamins or whoever has already discussed the vitamins will talk about these. But in any case, it is never going to possibly cause kidney. And that's about it. That's all.